Good afternoon, everyone, and welcome to our fourth presentation in our Reducing Preventable Hospital Readmissions webinar series. It is in this webinar series that we are focusing on targeted strategies for improving care transitions in our Virginia hospitals. My name is Joyce Daybalt, and I am Director of Performance Improvement here at the VHHA Center for Healthcare Excellence, and I am your moderator for this 30-minute webinar today. Before we get started, I would like to just go over some housekeeping issues. As you can see here on the slide, this webinar is being recorded, and it will be posted on the VHHA Quality and Patient Safety page in the next several weeks. The presentation is also located in your handout section in a PDF format of this webinar platform. We ask that you use the telephone option and that all participants in this webinar are muted. We ask that you engage. We'll have a question and answer session at the end of the presentation. We ask that you would type your questions into the question box on the platform there, as you see. And at the end of the program, we do have a very brief feedback survey that we would appreciate your input on so that we can continue to bring the best of presentations to you in the subjects that are beneficial. The purpose and objectives of this series has been for us to help our Virginia hospitals share successful strategies to improve their care transitions and help to affect reduction of hospital readmissions. And we also want to help to encourage transparency and facilitate network among our Virginia hospital, health systems, and community partners. This is just a quick table of the series presentations that have already occurred and the ones that are scheduled till the end of the year, just for your reference. Today's presentation is being provided from Sentara Williamsburg Regional Medical Center, and it's entitled Strategies to Reduce COPD Readmissions at the Regional Hospital, a Performance Improvement Initiative. I would now like to present introduce our presenter, who is Diane Priestley. She's a team coordinator for their integrated care management team process. And remember, we will leave the box open after her presentation for questions. Diane, the floor is yours now. Thank you.
All right, thank you, Joyce. Good afternoon. I'm happy to present this project to you all today. This was a project that I started out with as the CPI, which is a process improvement team at Williamsburg, where I am the site coordinator for the readmission team. So, of course, this addresses readmissions directly, and evaluating our readmissions, our COPD readmissions had actually gone up to our #1 readmission back in 2017, and we were not doing very well with those. So at the same time that I'm serving on this team, I also took my yellow belt training, and so I needed a project to do for any of those who are trained in yellow or green belt. I needed a project, and so these kind of came in hand, and that's how this whole project came about. So we'll go into how we addressed it using the yellow belt, which is the Lean Six Sigma approach for doing a project. So next slide, if you would. All right, so we named our project Strategies to Reduce COPD Readmissions at a Regional Medical Center. We are a 130-bed facility, so we're small in the big name of things, but want to do good work as well. So next slide. So our objectives, we first started out by gathering a team of interprofessionals from various places in our hospital. We had respiratory therapy represented, we had nursing represented, doctors, of course, our VPMA, quality was on there, and ICM, which is our name for integrated care management, our discharge planning department. And we had volunteer services, as well as, I'm thinking there's a few others in there, but we had a team of about 8 people who were all interested in working with the COPD population. So we just kind of got together and did a brainstorming of what we thought we could do to contribute to getting this rate down, and then basing it on some scientific research as well. So again, we did use the Lean Six Sigma approach to reduce this, and we started out by, the brainstorming was our original, and then we started to define our problem. So next slide, please. Our problem at Williamsburg, this is Sentara Williamsburg Regional Medical Center is what SWRMC stands for. Our COPD 30-day readmission rate was well above 20% consistently for like 6 months at the beginning of 2017. This is when we started looking at it. So our goal at that point was to decrease this rate. Our goal for the hospital was set for us at 17.5%. So that was our target that we were going for. So that was defining the problem. Next slide. Our measurement that we chose to use, we do have what we call a red light, green light report that comes out monthly from corporate that tells us what these rates were. So this was all based on our red light, green light report, which is a quality report that is printed monthly from our corporate, again, to evaluate the effectiveness. So this addressed the measurement period part of our project. Next slide. So you can see this is the red light, green light report dashboard that we used. As you can see under COPD 30-day readmission, starting in January of that year, we were 20, 21.7, 19. Anyhow, we were red. And so May is when we picked this up and we started implementing several initiatives that we identified. And as you can see, we did see a gradual decrease in our readmission rate. We went to get yellow and then finally ended up in green after about 6 months of implementing the interventions that I'm going to present to you in just a few minutes. So this is the data we were looking at and the measurements we were using for our project. So next slide. So our brainstorming, what we came up with was that we could address these COPD patients in several areas. Some of it's being while they were in the hospital. Some of it was preparing for discharge, preparing for discharge. And then once they are discharged, what can we do for them once they are back out in the community?
Readmission.
Somebody's not on
VHHA.
Could you please mute your lines, please? Thank you.
So anyhow, so these were the areas we were looking at, and I'm going to go into detail on each of these check marks that you see here. So I will tell you what we did to address those areas, and even an update since actually we've had about almost 8 months since we fully implemented things that we've been monitoring at post-implementation. So next slide, I'll go into the first intervention we did. All right, so what we identified was our respiratory therapy department absolutely was engaged in this, and they decided that they would like to have could become certified in COPD education. So there is a course that they could take on pulmonary disease educators course. It was a huge course to take, and there was a fee involved in that, but we had 2 respiratory therapists agree to take this course. It's 90 modules long is what they said, so it took them a while to complete it, but we successfully had 2 of our respiratory therapists complete this course, and what that does is they now provide more intense education to our COPD patients while they're in the hospital. So anybody that comes up flagged as a COPD patient, whether it's a readmit or an index admission, has one of the educators assigned to them, and they do extensive COPD education. So that was a big thing that took us almost a year to get completed, but we are happy to say we have 2 certified COPD educators on our staff now. Another part we did was with nursing, we did reintroduce and revise the COPD patient education toolkit. That is patient teaching that is system-wide for our Sentara system. All 12 hospitals use the same education toolkits, and it needed to be revised, so it was taken and updated and reprinted, and our nursing department was tasked with using those again and getting those back out to the revised copies out to our COPD patients. So nursing took that on and provided extra education as well as what the respiratory therapists were doing. So that was our big education push to do while the patient is in the hospital. Then we moved into what can we do to prepare them for going home that will make them be able to stay home and not necessarily bounce back as quickly. So the first initiative we took on was, as a system, our readmission team, system meaning all 12 Sentara hospitals, we're currently developing a new protocol on PCP, primary care physician follow-up appointments. And we're trying to get every patient that leaves out of the hospital to go home or with home health care, that they will have a follow-up appointment scheduled for them with either their PCP or a specialist, depending on what they're in for. So in this case, if it's a COPD patient, as long as they have a follow-up with a pulmonologist or their PCP within 7 days, was our objective to do this. So we accomplished this by actually educating our administrative assistants or unit secretaries on each floor to monitor the charts, and we had a column added into their work shows that showed all COPD patients. So system-wide, we were doing this based on as a readmission, high risk for readmission, got the PCP appointments. So we added all COPDers to that list as well. So in addition to just high risk for readmission, any COPD patient who comes in is going to have a follow-up appointment scheduled for them before they are discharged from the hospital. And like I said, our administrative assistants have taken that on, and they're doing a wonderful job with that. And along with that, our Sentara Medical Group, which is what the SMG provider stands for, are our doctors out in the community. They gave access to our administrative assistants to be able to go into their scheduling books, and they can actually schedule these appointments within the doctor's office right on their computer program, which facilitates us being able to get those appointments because they don't have to call and make the appointments. They can do it automatically on the doctor's scheduling schedule book in their office. So that was very, very helpful. So, and on to the next page. So that's preparing them for discharge. Next slide. Okay, access to medications and treatments was another barrier that we thought was a huge barrier for our patients. And particularly, I'm going to skip to the second one, but our MDI inhalers, and I'm not sure how other hospitals do it, but previously, any patient that was on an inhaler, an MDI inhaler while in the hospital, that inhaler was trashed when they were discharged, and we disposed of it. And the reason behind that was that it wasn't labeled for outpatient use. So we worked with our pharmacy department and found a program in Epic that they could actually relabel these MDIs so that they could the patients could then take them home with them, which releases them of the responsibility of getting their inhaler on the day of discharge, which is helpful, as well as gives them a little time, because as we all know, inhalers are rather expensive. It helps them to budget better to get their inhalers when the time comes. So they go home with their inhalers, whatever was left in their inhalers when they leave the hospital. We're sending them back to our pharmacy. They're relabeling them for outpatient use and then giving them to the patients on discharge. In conjunction with that, again, the inhalers has been a barrier because they're so expensive, and a lot of patients could not afford them when they go home and then find out their inhaler costs $200 or $300, and then they just don't get them filled. So we actually developed a new program. It's called the Breathe Easy program. And with that, we partnered with our auxiliary. We have a nonprofit auxiliary at our hospital here, and they provided funding for us so that if we identify a patient who could not afford their inhaler but had insurance, which meant they weren't eligible for our indigent program, that this program, the Breathe Easy program with the auxiliary funding, would pay for these inhalers for these patients who were falling through the crack of having insurance but not being able to afford their copays, which has helped quite a bit. And just as an add-on to this, both of these programs that we initiated, I just want to say now have gone Sentara-wide and have resulted in a new policy and procedure for both of these programs. Our MDI inhalers are now relabeled at all 12 hospitals, and it resulted in a new policy and procedure being drafted to do that. And the Breathe Easy program has been incorporated into our indigent program now, so that it has been stretched that it will include these inhalers even if the patient does have insurance, as long as they meet our criteria on their income criteria. So both of these programs for the medication assistance are new policies and procedures and have expanded beyond Williamsburg to include all 12 Sentara hospitals. So that has been a great help with our COPD population. And then lastly, last thing that we added to what we were doing is post-hospitalization. What we're doing is we have a program here called CIPHER, and what that does is they provide follow-up phone calls for the patients to see how they're doing, see if they got their prescriptions filled, see if they've been to see their PCP. Just basically, any patient that leaves our hospital gets one of these phone calls within 30 days of discharge. In addition to these CIPHER appointments, phone calls, you can add certain scripting based on diagnosis, and they did have a COPD-specific script that they can use, and so we looked into the COPD script, and it involved calling the patient 3 times post-hospitalization during that 30 days instead of 1 time in the 30 days. So it increased how often they were contacted to make sure everything was going okay and that they had what they needed. And so our hospital opted to pay for that. There is a fee, an additional fee per diagnosis, and so Williamsburg thought that was worth the value and added that to our CIPHER calling post-hospitalization. So some of the hospitals in Sentara have also adopted that, but not all of them at this point have adopted that. But we at Sentara Williamsburg have kept that as one of our initiatives, is to contact these people 3 times post-hospitalization. So we kind of addressed what was inpatient, what we can do to get them ready to go home to facilitate the transition, and then once they're home, how can we stay in touch with them? So that's what our goals, what our improvement plan was aimed at. And then on the next slide, you'll see our results for over a year afterwards. So our readmission rate pre-implementation, as you can see, was as high as 20.6. We started implementing in the summer of 17. We did not get everything fully implemented, I'll be honest with you. Did not get everything fully implemented for a year. It took us a year to get all these things done. And then consistently, we did drop down as low as 12.1, but kind of hanging out in the 15 range is where we ended up post-implementation of all of these interventions that I mentioned previously. So right now, we've been tracking it. We've done the few extra things. We've gone to JVON, which is an artificial intelligence screening that we do for our readmissions, and we're getting that implemented currently. But we're hanging out right now, truthfully, in the 17s. We're back at the kind of stabilized. The last check, which I did last week, our readmission rate for COPD was right at 17.3 with a goal of less than 17.5. So we're still making goal, but did slip a little bit up. Okay, next page. So at this point, we are in the control state where we're continuously monitoring, and like I said, we are at 17 right now, and addressing any new initiatives that we can do. JVON is our new initiative that we're working on. That is Sentara-wide, and we just went up on that in November, so we're not really sure if that's impacted or not. Doing some studying on that as the readmission team, and that's kind of where we are with that. Our COPD educators are planning to go to Rockingham Memorial Hospital, which is in one of our Sentara hospitals. They have navigators there that they're using instead of educators, and so they're going to get together and combine and see what they can learn from each other to maybe expand this program as well, is where we are. Okay, next page. Okay, perfect timing. Conclusion, so using the Lean Six Sigma methodology with a targeted audience such as COPD, we did see definite improvement in our COPD readmission rate. So we feel like we've successfully accomplished our goal, and we just have to maintain it at this point here at Sentara Williamsburg. Okay, next page, I'm done. So next page. Well, now we're
all right.
Answers. Perfect. You said give 10 minutes for questions and answers. Okay.
There you go. Thank you. All right, folks. If you have any questions, we ask that you would type them into the question box on your screen, and we will read them to Diane. We do have a comment for you, Diane. Great job and great result.
Oh, thank you. We actually got accepted at the national convention in Orlando that we're going to actually take this same project and present it in there in December of this year.
Excellent. We do have a question that's come up, Diane, and said, how difficult was it to get buy-in into the program?
Into a particular part of the program or the whole thing, I guess?
I'm not really specifying here. So, I mean, were there any spots that, the entire program?
Okay. Yeah, I mean, some things went off really easily because we kind of involved a different department for almost every intervention. Our hardest one was, truthfully, doing the medication assistance program that actually got escalated all the way up to risk management and to our legal department, and had to be, all the forms and everything had to be reviewed by the legal department, and that took a couple months. That was our hardest one to do, was just because they were worried that, you know, what we were incentivizing, and so we had to prove that we were not incentivizing these patients. But so we cannot offer to pay for their inhalers. What it is, it has to be that they have to say to us, I can't afford it, and then we can move in and provide them for the program. So it's not something we go out and can solicit, but if they bring that barrier to us, then we have a means to help them with it. So that was by far, pharmacists was the hardest buy-in on all of them. Everything else was pretty easy. Yeah.
That's great. A few more other questions have come. Wow, they're coming in. Did your organization have a hospital champion to help move the project forward?
Our VPMA, our Vice President of Medical Affairs, VPMA, was definitely our champion, and he pushed the things through the different departments whenever we would reach a barrier. Our VPMA was our person who actually was the one pushing when we had barriers, yes.
Excellent, excellent. Another question is, would you be able to speak about the caseload volume of patients during the improvement journey, and did the volume fluctuate at all?
Oh, yes, we did look at that. I don't have any of those figures in front of me, but we certainly looked at it for mainly the reason, and that's a good point, that's a great point actually, because we were down in the 15s and then we jumped up briefly up into the 19% readmission rate, and we couldn't figure out why. And when we looked at it, that was it. The volume was the problem, was our volume had cut in half. The number of readmissions stayed pretty much the same, but the number of 30-day readmissions stayed about the same, but our volume of COPD admissions cut in half. We went from like 200 admissions in a month to 100 in a month, but our readmission rate stayed in the about 25 to 30, so made our percentage jump way up. But we were looking at that maybe that meant our goals didn't necessarily always hit the 30-day readmission, but they were hitting long-term readmission, because that was decreased, our COPD admissions decreased in half after we implemented these interventions. That's
excellent, Diane. Another comment and question is one of the attendees, I am a COPD navigator RN and have managed to drop our readmission rates down doing almost all of these same things. We are hanging now at around 18%, but I can't get the buy-in from our hospitalist like I should. So what have you done to engage your hospitalist?
I guess we're kind of unique because we're so tiny. Being a small hospital, our hospitalists usually don't give us a lot of grief about things. And there's not a whole lot in here that they directly have to do, I think is the main thing. I'm trying to think what they don't have to order anything. Any of these interventions are independent of our hospitalists, so we don't really need. I'd be interested to know what you all are needing them to order, because all of our interventions are independent of the hospitalist to do. So we don't really need them for the buy-in.
Right. Okay. We'll give a minute more. We are 5 minutes to the hour of closing here. Give a minute more. If there are any other questions, please enter them into the question box, and we will share them with Diane. The same person, Diane, has said, we are a 480-bed hospital, and I changed the order sets, but the problem is they don't use them all the time like they should. So that was her feedback to you.
Oh, okay. I am not aware of a COPD order set that we have. And that's a good point. I need to look into that, but I am not aware that we have a COPD order set that the doctors are ordering.
Okay. Another question has just come into that says, how did you monitor the scheduled appointments for these patients?
Okay. We have a readmission CPI team, clinical process improvement team, that meets every other week by WebEx, and they actually do the monitoring of our follow-up appointments. And so we get a report actually monthly of how many appointments were made, how many were not made, and percentage-wise. And I actually just posted ours to our team because they're meeting right now, and we had a 64% compliance rate with follow-up physicians' appointments being made, which is not great, but our goal is actually only 40%, so it's above what the goal for the system is, but it is done by a Sentara Readmissions CPI team.
Gotcha. One more question. Did the reduction savings cover the cost of resources to implement and sustain your project?
Yes, because there was nothing that we really implemented that was real expensive. I mean, the educators was a couple $100 to do that, and the cipher calling was like a couple $200 to do that. So we haven't actually done a cost analysis of how much we saved, but I would say everything it cost to implement this was well under $1,000. So I would have to say yes, definitely.
Okay, good. Comments are thanks for the information and great work. And one last question, are you able to provide us a copy of the training provided to the nurses?
The training for the...
would that be the toolkit that you used for education? The toolkit, yes.
The toolkit? Okay, because we do order those as a Sentara system. They are something that is ordered, and yeah, I guess if you want to email me, I can get the information on where to order those.
Yes, why don't you just email it to me, okay, Diane, and I'll make sure that the attendee gets it.
Okay, yeah, because that's something we just order and have, shipped in. We didn't make it. We just update them as a system, and then they're, like I said, they're the same for all 12 hospitals. So gotcha. You want the ED toolkit information. Okay.
Yeah, just send that to me. Thank you so much. Well, we're only 1 minute left in our webinar time here today. I want to thank all of you for the robust questions, and Diane, your expertise and willingness to share this great program you all have put together. It has been very informative and an excellent presentation, a lot of interaction, and that's what we want our hospitals to have. So as we move forward, as this webinar comes to an end, we ask that you complete the feedback survey when you exit the webinar. And our next presentation will be on Thursday, August the 22nd, same time, same station. And Diane, again, thank you so much for a very excellent presentation. We appreciate your time away from your busy schedule and all your team members. We're very impressed with y'all's level of work in this. Thank you so much.
Thank you. You're welcome.